on the surgical anatomy and biomechanics, very important anatomy and biomechanics of the posterior cruciate ligament. I'll talk on these topics, the bundles of the PCL, their attachment, septum, nerve supply, vascularity, and biomechanics. To begin with, the posterior cruciate ligament is it's an extra synovial ligament. It is attached on the medial femoral condyle, and the length is 32 to 38 millimeter, while the cross section is 13 millimeter square. And the femoral attachment is twice as large as the tibial attachment. And it's divided into anterolateral bundle, which is larger, and the posteromedial bundle, which is smaller. The anterolateral bundle, the tensile strength is approximately 4 times as much as that of posteromedial bundle. And the attachment at the femoral side is smaller. Posteromedial bundle is smaller than that of anterolateral bundle. So when we're trying to reconstruct, or when you reconstruct the posterior cruciate ligament in single bundle reconstruction, we try to reproduce anterolateral bundle rather than the posteromedial bundle. That's because the attachment of the AL bundle is bigger, and the tensile strength is approximately 4 times as much as that of posteromedial bundle. And the conventional understanding is that the posteromedial bundle is taught in extension, while anterolateral bundle is taught in flexion. But there are certain cadaveric studies that have proved that these two bundles act synergistically. It may be in flexion or extension. They are taught almost to the equal extent in flexion and extension. And it's very interesting, or it's very important to learn the distal articular cartilage anatomy of the femoral condyles. This is the right knee at 90 degrees of flexion, and this is the sketchy picture of the same. And there is a sulcus terminalis. This is the sulcus on the lateral condyle. And this sulcus terminalis, this meets the edge of the cartilage at a convex point. And this convexity goes anteriorly, and becomes the apex of the intercondylar knots. This is the apex of the intercondylar knots. And as we go medially from the apex of the intercondylar knots, there is a convexity here. This is the convexity. And the end of the convexity is the trochlear point. And as we move posteromedially, it forms a medial arch. And this arch ends at a point called medial arch point. This is a medial arch point. And then the cartilage goes straight downwards. This is the straight cartilage. And here is the posterior point as well. And there is another osseous landmark. This is very important osseous landmark. This is both visible and palpable, and this is present along the medial intercondylar ridge. This is called bifurcate prominence. So now we've got 3 points: trochlear point, middle arch point, and bifurcate prominence. And if we take the center of this prominence, center of this triangle, then that forms the center of anterolateral bundle. Though bifurcate prominence may be difficult to visualize in the live knees, but if we clear the footprint of the PCL, we may see the bifurcate prominence, but we don't actually clear the entire footprint because of several reasons we discussed in the later slides. So if we take the center here, and if we make a drill hole here, it forms the anterolateral bundle. This is anterolateral bundle. And beneath the posterior to the anterolateral bundle is posteromedial bundle. This is smaller as shown in the figure itself. And anterior to the posteromedial bundle is anterior meniscus femoral ligament, also called ligament of Humphrey, and posteriorly is posterior meniscus femoral ligament, also called ligament of Risberg. And these two meniscus femoral ligament sort of clasp the posterior cruciate ligament like a fork, and thereby this provides stability to the posterior cruciate ligament in case the PCL has been torn. On top of that, the ligament of Humphrey and Risberg, they also provide certain degree of anterior posterior stability. And these ligaments are attached to the lateral meniscus posterior horn. And again, it's very pertinent to understand the anatomy of the tibial condyle as well. This is the posterior view of, of the tibial condyles, and this is the medial tibial condyle, and this is the mid-sagittal section as we see in the MRI, and this is the lateral tibial condyle. So the anatomy is quite different from as you go from the medial to the lateral. It is not uniform as we see in the plain X-ray. And let's focus on the mid-sagittal section here. This can be compared with the Sampen glass. This is a Sampen glass, and this is the convexity, the slope going anteriorly. And if we compare this Sampen glass drop-off to the mid-sagittal section, this can be compared like this. This looks like a Sampen glass. And this point is called Sampen glass drop-off, CGD. This is the point actually. And the slope goes suddenly and anteriorly and it resembles the Sampen glass. So this is also called Sampen glass drop-off. And there is another facet called PCL facet. This is a shallow depression where the PCL is attached. So we try to make a drill hole somewhere around this PCL facet here in case of PCL reconstruction. And another important point is the popliteus muscle. This lies just, sorry, this lies just beneath the capsule. This purple circle represents the capsule. So if we are able to see popliteus muscle, either it's been torn because of trauma or we've made injury to the capsule so much so that the popliteus muscle is visible. So this is the mid-sagittal section, and it's very important to understand the anatomy of the mid-sagittal section. And both the anterolateral bundle and the posterior medial bundle, they take their attachment, tibial attachment in this facet. And this is the mid-sagittal section. This is the popliteus muscle. And this is Sampen glass drop-off. It is actually not transverse. It is actually oblique that grows to a lateral part and the superior part. So this is how CGD, also called Sampen glass drop-off, is formed. And this is the popliteus muscle. Just beneath the Sampen glass drop-off, popliteus muscle is visible. So during surgery, we don't want to actually visualize the popliteus muscle. We stay proximal to this muscle. And there is another ridge called bundle ridge. This actually separates the anterolateral bundle from the posterior medial bundle. And the bundles take their name, anterior, posterior, from the attachment on the tibia, not from the femur. And there's another landmark called shiny white fibers. These fibers are present just beneath the posterior root of the medial meniscus. So, and this is important landmark. This is very shiny and it's visible in few cases of PCL reconstruction. And we should be very careful while releasing the septum or while working on this depression, because not to injure the meniscus, especially the medial meniscus posterior root that lies slightly posterior as compared to the lateral meniscus. And we should also be careful not to make the ramp lesions and not to injure the coronary ligaments that are present around these areas. Actually, this is a very small area. So this is the blue one represents the anterolateral bundle, and this one represents the posterior medial bundle. Actually, we try to reproduce the anterolateral bundle in single bundle reconstruction of the PCL. And the septum anatomy is again very important to understand. This is the septum actually is the this layer. This is the layer that attaches the posterior aspect of the PCL all the way up the capsule. So in case of fully extended knee, the distance from the PCL attachment site to this neurovascular structure is about 4 millimeters. And this is the septum. Actually, the septum lies very close to the popliteal artery. And this is formed out of two thin fibrous membranes with intervening fat and synovium. It has intervening fat, and the outer layer is synovium. But as we flex the knee, the, the neurovascular structure goes slightly posteriorly, but that may not be sufficient enough to, to take the neurovascular structure much farther posteriorly. So what is the way out? What is the way to stay much away from the neurovascular structure? We we actually release the septum here. This is the septum part, and the superior part of the septum has some vascularity. So we don't want to disturb the superior portion of the septum because it has some vascularity and it's going to supply the blood vessel to the new reconstructed graft. So we stay inferiorly and anteriorly, not posteriorly. So we make two portals, posterior medial and posterolateral. We need to make the portals because if we work only with the anterolateral and anteromedial portals, the blind spot is approximately 21.5%. So we want to make two more portals. And if we do not release the septum even after making the portals, then the blind spot is still 8.4%. So we want 0% blind spot. For 0% blind spot, that is no blind spot, we have to release the septum. And another advantage of the septum is after releasing the septum, the distance from the tibial tunnel of the PCL up to the neurovascular structure increases from 4.4 millimeters to 14.7 millimeters. It's approximately 1 centimeter posteriorly. So the neurovascular structure goes 1 centimeter posteriorly, and we've got enough room to play with very little risk of injuring the neurovascular structure. And on top of that, the blind spot is approximately 0% with this transseptal release. This was actually proposed by Anne et al. In 2007. And this posterior cruciate ligament has a lot of mechanoreceptors. These are more concentrated on the femoral attachment. So that is the reason we don't want to disturb, we don't want to damage the native footprint of the PCL, especially in the femur, because there are a lot of mechanoreceptors. And this is the concept behind the remnant preserving PCL reconstruction. So because of this reason, we may not see the bifurcate prominence as I talked in the first slide. And these mechanoreceptors are also present on the superior part of the septum. And because of this reason, we don't want to divide the superior part of septum. We want to stay on the inferior part of the septum. And the vascularity is by middle genicular artery. Biomechanics of PCL is actually I've oversimplified in this slide because it's quite complicated, and we can understand in different manners. This is a rigid bar actually, and this is the green one represent PCL, while the blue one represent the anterior cruciate ligament. So this rigid bar is not going to change from extension to flexion, while these three bars, they change their position. And knee actually is not purely gliding motion and not purely, it's actually a combination of gliding with rolling motion, because of which this flexion is possible. And as we flex our knee, the center of motion gradually changes, goes toward posteriorly. That's because of different radius of curvature of the femur at different points. And this portion has wider radius of curvature, while this portion has smaller radius of curvature, because of which the gliding and rolling motion is possible here, has to take place. And it is the ACL and PCL that guide this gliding and rolling motion. So the reconstruction of the ACL and PCL, the tunnels have to be very precise. So as you flex the knee, the rigid bar stays in its position, while other bars change their position in this way. This is the biomechanics of PCL, and this is called 4-bar linkage system because it consists of 4 bars. Another biomechanical function of the PCL is it resists posterior transmission of tibia. And this is the PCL intact knee and the PCL deficit knee. So as it resists the posterior translation in PCL deficient knee or PCL torn knee, the tibia tends to go posteriorly. So the pressure on the patellofemoral joint is increased because of this posterior sagging, especially in the flexion in deeper degrees of flexion. Because of this increase in patellofemoral pressure, the patellofemoral OA osteoarthritis sets in, and the patient complains of anterior knee pain in case of chronic cases. And it's very interesting to note that in the early stage, the patient complains of pain on the posterior aspect of the knee because of the pathology, because of the PCL tear. But as the chronicity sets in, the patient has patellofemoral osteoarthritis and he complains of pain on the anterior aspect of the knee. And the chronic it is, the more the pain may be complained of by the patient. And the weight bearing mechanics is disturbed here. In case of PCL intact knee, the weight passes through the menisci and then to the tibia. But in case of deficient knee, as the tibia sags posteriorly, the weight transmission, the kinematics of this knee joint gets disturbed. And all the weight may not pass through the meniscus. Some weight may pass through the cartilage as well. So this leads to middle compartment osteoarthritis, most probably on the middle part, not on the lateral part, most probably because of the middle menisci are firmer than the lateral menisci. And the lateral meniscus, because of its attachment with the femoral condyle via meniscofemoral ligament, the lateral menisci tend to move with the femoral condyles. So the weight passes in the lateral meniscus through the meniscus, in the lateral compartment through the meniscus to the tibia, in spite of the PCL tear. While in the middle compartment, since the middle meniscus is firm, the weight passes through the femoral cartilage directly to the tibial cartilage, thereby causing middle compartment osteoarthritis. So these are two important considerations in case of a PCL tear. Another consideration is PCL's action is also to resist the external rotation of tibia. So in case the PCL has been torn, the tibia rotates externally, or in case of closed chain motion, the femur rotates internally. Because of internal rotation of the femur, the pressure is more on the lateral patellofemoral area. So the osteoarthritis is more on the lateral patellofemoral articulation rather than in the whole of the patellofemoral cartilages. So these are the primary actions to resist the posterior translation and external rotation. And besides this, there are other structures like popliteal ligament, the collateral ligament, of course the capsule, that help the PCL in these biomechanics, in resisting the external rotation and in resisting the posterior translation of the tibia. So this is another cause for patellofemoral osteoarthritis in case of PCL deficient knee. This is a very brief on the anatomy and biomechanics of the posterior cruciate ligament. Thank you very much.